Well, hello, I'm Dr. Michael Miranda. Such a pleasure being with you again on another Medical Minute. And today's subject is peripheral neuropathy. We're talking about bundles of nerves that exit the central nervous system as long neuronal axons. And some of these nerves are ensheathed, myelin-sheathed, and some of these nerves are unmyelinated. The functionalities of these nerves tend to be sensory, motor, or autonomic. And usually the pattern of the neuropathy is seen in a distal moving to proximal anatomic location, meaning oftentimes you will find symptoms and signs relating to the toes, ankles, then legs, and then moving proximally up the thigh. In the general population, the incidence of peripheral neuropathy is about 2.5%, but in the type 2 diabetics, it's as much as 25%. It's seen also commonly in people with hypothyroidism or myxedema. And perhaps most commonly, people experience peripheral neuropathy subject to entrapment, as in carpal tunnel syndrome or ulnar neuropathy, ulnar nerve neuropathy, or that one that affects the lateral leg that lends to the peroneal nerve being compressed or entrapped. And this is probably the most common type of neuropathy. But generally, if you think of the word Smith, then S would allude to a lot of systemic diseases that could cause neuropathy. M, certain medications. I, infections. T, toxic. And H, hereditary causes of peripheral neuropathy. Clinically, patients present with pain, numbness, tingling, weakness in the affected area, usually in a dermatomal pattern and or a glove and stocking type of pattern. Clinically, patients will present with signs and symptoms of this peripheral neuropathy. They'll complain of numbness, they'll complain of tingling, of weakness, of pain in the affected areas. And it tends to be in what they call a glove and stocking distribution, meaning it would, just as if a glove covers your hands or a sock covers your leg. The patient will probably have decreased sensation to light touch or pinprick in the affected area. They might not be able to appreciate variation of temperature, whether warm or cold. And they also sometimes lose position sensation, sometimes not knowing whether their toe is forward or backwards. And also sometimes they lose the sensation to vibration, often tested by using one of those 128 megahertz tuning forks that oftentimes we just put it on the medial malleoli and see if the patients can tell when it's vibrating as to when it's not vibrating. Once we have localized the lesions, then the next step is to try to diagnose what's causing the neuropathy. And this can be quite challenging, which is why some 20% of peripheral neuropathy etiologically go undiagnosed. However, some conditions, as we said, are commonly associated with peripheral neuropathy, that of the seen in the diabetics, as we said, type 2, about 25% of them will have it. Hypothyroidism or myxedema, people with HIV disease, people with herpes zoster or shingles, people with vitamin deficiencies, and people with entrapment or compressive neuropathy. Those are a little bit more easy to tie down. But if we just think of the mnemonic Dick TV clip, That will help us with some of the systemic causes of peripheral neuropathy, where the D is for diabetes mellitus. The I would be for infections, for instance, HIV disease, leprosy, as I said, shingles would be a common one, and another common cause is Lyme's disease. At one time, they were said that one of the most treatable causes of peripheral neuropathy in the world was in relationship to leprosy. That was some 20 years ago. I'm not too sure what the status is these days about that. K would be for kidney disease or end-stage renal disease. C would be for critical illnesses. A lot of times people critically ill will develop vague or various forms of a neuropathy. T would be for thyroid disorders, specifically hypothyroidism. V would be for like vitamin deficiency, commonly vitamin B or vitamin B6 deficiency, oftentimes associated with a neuropathy. C again could be for cancers. A lot of neoplastic conditions are associated with neuropathy, and sometimes there's a paraneoplastic screening that's done to try to elucidate whether it's from a neoplasm that a person is getting neuropathy. So lymphomas are oftentimes associated with a neuropathy. Liver diseases is associated with, chronic liver disease can be associated with a neuropathy. Inflammatory or immunological causes, lupus, commonly seen. Neuropathy can be associated with things like multiple myeloma or immunoglobulin A, G, or M disease. And the other one that oftentimes you see a neuropathy associated with it is that of porphyria. Then sometimes you have toxic causes of a neuropathy. And the mnemonic I try to fathom for toxic causes is that of atomic D. And A would be for like alcohol, especially ethanol, is oftentimes associated with a neuropathy. L atomic T, tetanus, organophosphates. Atom M for metals, heavy metals, gold, arsenic, lead, mercury, gold, as we said. D would be like diphtheria toxin as far as toxics are concerned. Then you have peripheral neuropathy sometimes associated with it with certain meds, and the list is long. The ones that come to mind more quickly is that of the isoniazid. Isoniazid, part of that TB regime, where you always are encouraged to give vitamin B, especially B6, whenever you're given that medication. But a lot of medicines that include amiodarone, hydralazine, and as I said, a long list of medication. Charcot-Marie-Tooth disease, type 1, type 2, and then there's idiopathic polyneuropathy, which we say can be some 20% of reasons for neuropathy. The evaluation then of anybody with a peripheral neuropathy, once you've made that diagnosis, is a lot of times people are just going to do blood screening, and the things that they're looking for is the B6, the B12, the thyroid function. A lot of times you're going to screen the patient with a RPR, seeing if they have any type of leprosy or even syphilis, and sometimes you're going to need to do collagen vascular type of workup. Possibility of lupus is there. CBC, you're looking for things like a myeloma, or anemia that would probably implicate whether a neoplastic process might be occurring. So you're going to do a CBC, you're going to do CMP, looking at your liver and your kidney functions, and hopefully from that you'll find something that will help you to target in on what's causing. If not, you're probably going to have to go on to do electrical studies. The electrodiagnostic studies include that of nerve conduction studies, or the EMG, electromyograph. The results from the EMG will suggest whether you have a demyelinating injury or an axonal injury. Where there is an axonal injury, there tends to be decreased amplitude in the waves. Where there is a demyelinating injury, you tend to have more latency and slower conduction. You're looking at the shape, the amplitude, the latency, and the conduction velocity. And this is how they made that differentiation as to axonal or demyelinating injury. Some of the medications that were involved in possibly causing peripheral neuropathy, of course, included the amiodarone, chloroquine, digoxin, isoniazid, a lot of the medication used for cancer treatment, vincristine, cytostec is one of those stomach medications that can be associated with the peripheral neuropathy. Statins, a lot of times more sensory, but in my experience I've seen motor peripheral neuropathy associated supposedly with statins. Vitamin B6 excess, dilantin are just some of the medications that can cause peripheral neuropathy. And so the diagnosis of the peripheral neuropathy, once you've looked at the blood test, if you find a reason, then you can go ahead and treat it. If you don't, then you move to the electrical diagnostic studies, the EMG and the nerve conduction studies. And if it suggests an axonal injury, you might be thinking more in line for the diabetes or toxic reasons, or meds that could be causing it, or thyroid disease, vitamin deficiency, or hereditary disorders, and or vasculitis, which is pretty common causes of peripheral neuropathy. So you might definitely want to look at the ANA, the rheumatoid factor, and sometimes you just have to be looking for perinuclear anti-neutrophilic cytoplasmic antibodies. Definitely we say that you want to do your RPR, looking for your serum protein electrophoresis. Got to think of myeloma as a possible cause. And look at the meds. If the nerve conduction suggests that it's a demyelinating injury, then you might wonder whether it was a hereditary condition, especially if it was a uniform demyelination, or if it was non-uniform, you might think of subacute or chronic inflammatory demyelinating polyneuropathy and or acute Guillain-Barré syndrome. If you get a mixed picture, then you wonder if it's a demyelinated disease or axonal disease. You're not too sure. If it's normal, then you really haven't ended up with a diagnosis, and a lot of times you'll have to go to nerve biopsy to actually see if you can get a pathological diagnosis as to what's causing the problem. So once you have made a diagnosis, then you want to lend some attention to treatment. And the treatment is twofold. One is you want to treat what's causing the problem, and secondly you want to try to address therapy for the symptoms. Clearly, if you find that you have a problem with toxicity from meds and you want to remove those, or if you have a vitamin deficiency, you want to replace that, for instance. If you have an inflammatory condition going on, then you want to use some steroids. And you have to be wary of the acute inflammatory neuropathies, which is a much more urgent situation where you might have to consider mechanical ventilator support. And the other thing, of course, you want to control some of the symptoms. Usually we're talking about pain management primarily, and people use Neurontin, Topamax, Tegretol, opioids, Lyrica, non-steroidal anti-inflammatories. Topical Zostrix is sometimes used for the neuropathy, and usually 0.25 or 0.75% of Zostrix. Recently I've heard of them making a preparation that's 8% of capsaicin in the mixture of the Zostrix-like agent. And so this is really important because it can be quite a nightmare to have the pain or the depression that sometimes even accompanies having this syndrome of peripheral neuropathy. Alright, Dr. Mirander here in another Medical Minute, Peripheral Neuropathy. See you next time.